So we're going to get started because Dr. Saint-Phard has to leave at 7, so we are going to start on time. So tonight we're having a presentation from Deborah Saint-Phard. A little background: she did her undergrad at Princeton University, medical school at Temple, came here for residency, and then went on to Mayo to do a sports fellowship. Spent a few years in New York at Weill Cornell, and then came back to CU, where she is the founder and director of CU Women's Sports Medicine Program. Her prior research was in stress fractures and now has developed an interest in physician resilience. So that's what she's going to talk about tonight.
All right. Thanks, Adele, Chris, and the Department of PM&R for inviting me to give grand rounds. I'm excited to do this. I'm excited to just talk about things that I don't think we think about, but impact us on a daily, if not a moment-by-moment basis. So we're going to start talking about the health of physicians. I have no financial disclosures. And the objectives for tonight are to be able to define physician burnout, to be able to note the prevalent trends in physician burnout, to increase awareness of physician resilience resources here at the university, in the School of Medicine, and also to increase the awareness of the critical need for physician self-care in order to thrive personally and in the care of others, to know where to turn for guidance and growth. 60% of practicing physicians experience and report symptoms of burnout. There's no specific DSM criteria or diagnosis in the latest manual, and the World Health Organization identifies and speaks about burnout in terms of a state of vital exhaustion. Maslach's conceptual and operational definition is as follows. It's a triad of emotional exhaustion, which is emotional overextension and exhaustion, depersonalization, which is a negative, callous, and detached response to others, treating others as objects, and reduced personal accomplishment. Feelings of competence and achievement in one's work are reduced. This should shock everybody in the room. The suicide rate among female physicians is 2.3 times higher than women in the general population. I thought physicians were healthy. I thought physicians, would be sort of the best of the best in terms of caring for themselves, and this was particularly shocking to me. 400 doctors committed suicide last year alone. The suicide rate among male physicians is 1.4 times higher than men in the general population. You're going to live longer if you don't become a physician. Suicide is an occupational hazard for physicians. There's a study of U.S. medical students done by Derby. 2008, 4,287 medical students were studied across 7 different medical schools, including private ones and government-funded ones and public institutions. And she looked at the prevalence of suicidal ideation in the past year between 2006 and 2007. 50% of those medical students were experiencing burnout, and 10% were experiencing suicidal ideation during medical school. Many of the medical students, before they came in, at the time of matriculation, were healthier on all of the studies and parameters that they used in comparison to the general population. So there's something specific about the medical school education, training, and environment that leads to this. Burnout is associated with an increased likelihood of suicidal ideation, and recovery from burnout is associated with less suicidal ideation. One of the measures that's a gold standard for looking at burnout is the Maslach Burnout Inventory. It's a 22-item instrument. It takes, I think they said 5 minutes to fill out. And the subscales that have been validated that are concordant or match up with burnout from this are on the emotional exhaustion scale, the depersonalization scale, and the low personal accomplishment scale. Extensively, this inventory has been used with physicians and medical students. It has a discriminant and convergent validity, construct validity of 3 dimensions, and predictive validity for future absences from work if there is a high burnout score. And here is an example pulled from this paper where the medical students were, some of them were never burnt out. So this is the suicidal ideation in the past year, is on this axis. And those who have never been burnt out experience the least amount of suicidal ideation. And those who recover from burnout, the next highest amount of suicidal ideation. And this was a comparison between 2006 and 2007, so they went back in a cross-sectional way to the same population over at two different points 1 year apart. The newly burnt out folks had a higher percentage, and then the chronic burnout had a highest percentage of suicidal ideation. And everybody's probably familiar with the Mount Sinai students who are jumping from 8th floor buildings to commit death during their residency. 3 of them have done that. 3 of their students have done that in the last 18 months. And that was as recent as, I think that was in August, was the most recent 27-year-old female from a suburb in Connecticut, completely healthy, completely happy, completely excited to be pursuing orthopedics in the future, and jumped to her death. Looking at depersonalization on this axis, and then emotional exhaustion. These were, so some people say, oh, so they must be depressed if they're doing that. Well, burnout and depression are independent variables as it relates to suicidal ideation. So green is the people who screen positive for depression, and then the white are the people who had negative depression scores, but still the burnout is independently elevated, and with suicidal ideation here on this side for both those who are in depersonalization and emotional exhaustion elevations. What is the cost of physician burnout? Physician attrition, in studies looking at PCPs who leave the field, it's $250,000 to replace them. Independently, physicians who are burnt out provide poor quality of care. They have poor patient satisfaction, increased medical errors, lawsuits, and a decreased ability to express empathy. Substance abuse, automobile accidents, and stress-related health problems, as well as marital and family discord. So some of the contributors to burnout that physicians report are a lack of a sense of control, and also a loss of meaning. Being present with patients correlated to increased meaning in work for internists, and so losing that ability to be present is a critical factor. So we're going to talk about mindfulness and how to develop more of that later. Other outcomes: absenteeism, poor job performance, incivility, turnover, health problems, depression, higher costs for the organization. And this is all preceded by declines in empathy and well-being during medical school. Burnout during residency, this is a meta-analysis. I'm not sure if it's projecting very well. It's kind of small. But looking at across multiple different studies, the different rates of burnout that are I don't think so. It's too small, right? All right, I'll figure that out. Those are just examples. This was stunning. Dr. Laker sent this one around. Looking at, Schoenfeld did a study where they compared these surveys on physicians in 2011, and they went back three years later in 2014, and to note what was the difference. Was there a difference? Was physician burnout going up or going down or staying the same? And physical medicine and rehabilitation, you can see at the top of the list there. I was shocked to see that. That over that 3-year period, physicians in physical medicine and rehabilitation were the top 3 on this list for increasing sense of physician burnout. Some people attribute this to the increased access from the electronic medical record. Now, patients can get you anytime they want, just with a simple email, and it used to be a phone call, and it's coming directly to your inbox, and you have to manage that. Many physicians cite the electronic medical record also its presence as increasing physician burnout and not actually diminishing it or taking it away. The other specialties, emergency medicine's topping the list, urology, which I find that really interesting. I'd love to see what they're thinking. PM&R, which is concerning. This is another way to frame this that I think is really easy and nice to see. So if you're looking to have a good life, it looks like you need to be in the green box, where the percent satisfied with work-life balance is on the y-axis, and the x-axis is people who are burnt out. So urologic surgery, something's going on there, super unhappy. PM&R is right over here. So a high amount of burnt out. According to this, they're right about, we are right about 64% feeling burnt out, and 43% satisfied with work-life balance. This paper concluded with this call for action. Burnout and satisfaction with work-life balance among U.S. physicians is getting worse between that period of 2011 and 2014. American medicine appears to be at a tipping point, with more than half of U.S. physicians experiencing professional burnout. Given the extensive evidence that burnout among physicians has effects on quality of care, patient satisfaction, turnover, and patient safety, these findings have important implications for society at large. There is an urgent need for systematic application of evidence-based interventions addressing the drivers of burnout among physicians. These interventions must address contributing factors in the practice environment rather than focusing exclusively on helping physicians care for themselves and training them to be more resilient. So Adele Marone helped me do an informal survey, which many of you took part in, and I appreciate that because we'll be able to give you in real time a reflection of how y'all are feeling. Total number of respondents for the residents, 14 out of 16 responded, which is an 87.5% response rate, which is off the charts for response rates, which are typically 40%, which the faculty represent. 16 out of 38 faculty responded, with a 42% response rate, which is typical response rate. Average hours a week worked per week by the residents is 54 hours per week. And then in 2003 was when the mandatory restriction on work hours went into effect for residents being less than 80 hours a week. So at least the residents are there, our residents. Faculty, 46 hours a week. So this is the chart. I'll let you guys look at that. So there were 3 questions that were asked, and these were totally taken from the Maslow burnout inventory, but it wasn't the full 22 inventory. These were just lifted out just to give us a snapshot into how people are feeling. Does anybody see any concerns? Yeah, I agree. That's a concern. A few times a week, 2 residents were feeling everyday burnout. A few times a week, 2 other residents feeling everyday burnout. And I think we're feeling acceptable if people, I don't know, what's acceptable to us? Should you be feeling burnt out a few times a month? And is that going to be different for every person? Because every person, for one person to feel a sense of burnout, we all register that differently in terms of how we handle that. And so that's really what we're going to be talking about, is how we each position ourselves to manage what we're feeling, and then also institutionally and systemically, the systems that we're working in, what can we ask as physicians? And the PGY 2s and 4s, we're going to be meeting because I want to hear what is it that we need to ask for you to feel responded to, listened to, and creating an environment that works for you. So this is important, and this is just, today is the beginning of this conversation. Faculty, yeah, sorry. We're going to get to that. There were a few comments, but again, this was just a snapshot. So this is the beginning of a conversation. Faculty, anybody see anything that they're concerned about? Everybody's good? Faculty's happy? Moving on? All right, we'll move on. But I'm, yeah. Right, right, and I think it's something that we don't talk about, and we talk about it when, residents in New York are jumping out of 8th floor dorm rooms to their death. And I'm sure their parents are like, I should have never let her go into medicine. It's like, would you counsel your children to go into medicine with these statistics that you're seeing today? We've got to fix something. Residents' responses to, I've become more callous toward people since starting this job. Thoughts? What do you see? Happy, not happy, concerning, not concerning? Concerning? I agree. This is the business. We're in the business to care, right? We're in the business to bring our best, and to deliver it and to share with people and to be privileged to have people share with us. And when that changes, the question is why, and what can we do about it, more importantly. Faculty. Are faculty feeling callous? One of the things in the literature that they talk to institutions, it's like you have to be very, very, this is most important at the faculty level because your faculty is non-changing. Administration can change, residents and trainees change all the time, but the faculty has to be the healthiest part of your department. So how are people feeling about this? Concerned, not concerned? All good? Problem? Yes? Yeah, and this is all physician self-report, which is, it's interesting and illuminating. Residents, you feel balanced? We are out of here at 7 o'clock. I'm promising that, so that you can get home to your families or to your self-care. It's critical. All right, so residents, happy, unhappy with the way this looks? One quarter of the respondents, don't feel like there's work schedule balance. A lot of people do. That's great. Neutral, all right, we'll take that. But I want everybody down here, right, to agree or strongly agree. And I think that that's what we should be working towards. Faculty, stay here, day in, day out, year after year after year. You guys happy with this? I'm not happy with this. We need to work on this. We need to talk about this. We need to effect some change. Some of the comments from the resident side include parenting during residency is immensely challenging, better work-life balance in other medical specialties. However, feeling strained is very dependent on my work environment, so some rotations are more trying than others. Compared to my peers in other residencies, I have far more time towards self-care. However, compared to my peers in other career fields, far less. And that last point is critical and across the board in all literature reviewed, that the comparison between the medical career versus any other career on the planet has less burnout, or has more burnout and a perceived sense of time for themselves than any being an attorney, your neighbors, and this is all out there. Faculty comments. Recent changes in my organization have contributed to my sense of burnout. This is all reflected from those surveys. It does still tend to creep into my off time a lot, and that's the work. Clinic load plus unquantifiable faculty time that isn't accounted for is the greatest pressure and creep of the job. That and notes that I don't get done in clinic because of interruptions. Other objections centered around lack of control of schedule hours, which in the literature is another key component for what drives physicians to feeling burnt out, is the lack of control of schedule and hours, and this was reported by one of our faculty. And perception of poor leadership also impacts. Let's talk about the science of resilience. I thought about putting the hypothalamic pituitary axis chart up here and drawing circles around the brain and the amygdala and the hippocampus. I thought about it. Somebody just did that in the conference and I just glazed over. So I won't put you through it, but you know what it looks like, and this is what we're talking about with the science of resilience. This is a brilliant paper. Southwick in 2012 is published in the Journal of Science. If you're looking to pick something out for the basic scientists in the room, you'll enjoy it. I'm talking about neuropeptide Y and a lot of the genetic markers for depression, as well as how resilience strategies impact our genetic alleles. For some of us are wired more towards that, but also the solutions for getting around that, even though there might be a genetic or an epigenetic contribution towards resilience or depression. That paper is about resilience and depression. So resilience is the ability to bend but not break, to bounce back, and sometimes even to grow when faced with adversity. And here's the key thing. Anyone can learn to become more resilient. So if you're feeling resilient, awesome. If not, there are many, many things that can be done. And this, I thought, was a beautiful, beautiful table. So they were tying resilience to depression, and that's not so just looking at that. So depression risk factors, the cognitive behavioral scale would be weak executive function, weak coping or self-efficiency, negative attention bias, and cognitive inflexibility. Therapeutic intervention would be cognitive behavioral therapy with cognitive reappraisal, positive emotion exercises, coping skill development, and training and well-being therapy. So this is great. Resilience protective factors. This would lead then to strong executive function, high coping self-efficacy, positive emotions, realistic optimism, and cognitive flexibility. And cognitive flexibility becomes a super, super important concept for people getting to be more resilient. A lot of times we're trying to, and I think if I can do this broadly, a lot of times we're trying to control everything in our environment and not have it change or have it be just the way that we need it to be. And if you can train yourself to be more cognitively flexible, you will be happier. And there's data for this. Emotional regulation. So weak regulation is a depressive risk factor. The intervention would be mindfulness training or antidepressant medications. And then the resilience protective factor, that it gives you a strong regulation so that you can delay gratification and rapid stress recovery. Socially, if you have weak social skills, this is a depression risk factor. You can intervene with social emotional training, and then you get strong social skills, diverse social network, and more resilient role models. Physical health, if you're sleep deprived, if you're poorly cardiovascular fit, if you have poor nutrition, if you're obese, these are all depression risk factors. Tons of evidence for cardiovascular training and good nutrition. So you teach sleep hygiene, exercise regimen, and improve the diet, and that leads to strong sleep habits, physical fitness, and good nutrition. And these things are key. Neurobiology. So this dysregulated hypothalamic pituitary axis, which you know, and I didn't show, keep you awake, and the sympathetic nervous system in response to stress is a depression risk factor, and that's the genetic model that he was talking about in this paper. Attenuated prefrontal cortical executive function and stress-induced limbic system hyperactivity. The intervention is neural circuit training, novel medications, neuropeptide Y, corticotropin releasing factor, and then this leads to effective regulation of the hypothalamic pituitary axis and central nervous system in response to stress. And so it doesn't get dinged, it responds and bounces back faster with stress. So he points out 10 key elements. Southwick points out 10 key elements for resilience. Positive emotions using optimism and humor, emotional regulation of fear and anger. Coping styles should be active and approach versus passive or avoidant. Social support, cognitive flexibility, spirituality. Pick a spirit and follow it. Pick any, it doesn't matter, but you need to be tuned into something and get yourself grounded. Moral code, including altruism, resilient role models. You see somebody who's just kicking it, it's easy, they're happy, it's like, figure out what they're doing. That's what I did when I was failing in medical school. I was like, oh my God, she's kicking it. Everything's easy. She's getting A's. I started studying with that person, and then my grades went up. Same thing. Purpose and meaning, and then training of certain skills. So let's talk about mindfulness, which is the direction we're going in. The awareness that emerges through paying attention in a particular way, on purpose, in the present moment, and without judgment, to the unfolding of experience from moment to moment. Mindfulness-based stress reduction has to do with reducing stress, reducing rumination, reducing negative feelings, and it enhances a capacity for empathy. So it's really what we all need to be doing in response to what we started talking about at the beginning. Epstein has written that clinicians must also realize that they have a choice about stress. When I read this, I thought, really? I don't know. But it's really about learning to self-regulate our own cognitive, emotional, and somatic reactions to whatever reality we're in. Zwack studied resilient physicians in Germany. Those physicians, she talked to 200 of them, valued owning up to their own limits, uncertainties, and errors, embracing greater self-awareness around professional competence and their own sense of well-being. Epstein laments that our current system of educating physicians and the practicing physician is left alone to find ways of enhancing their capacity for self-regulation. So you get into the system, you get banged away in medical school, and you're expected to figure out your way. You're expected to figure out how to keep working out, how to keep doing self-care with the same coping mechanisms that you had entering the door. When you entered the door in medical school, you were healthier than your peers. But at year 1, year 2, year 3, you're far less healthy than the general population of age-matched controls. And so we have to set boundaries around one's work to have enough time to actually relax, proper sleep hygiene, spend time with your family, and proper nutrition. He notes that resilience, which is a wholehearted engagement with, not a withdrawal from, the often harsh realities of the workplace. And that seems paradoxical, that the loss of resilience can result from seemingly energy-saving measures of withdrawal. What does that mean? Oh, my not getting up for 5:30 a.m. conference on Wednesdays, for sports medicine conference, and my withdrawal from that. So I showed up today. It's changed my life. Did I not? You saw me there? 6 a.m.? All right. And I do. I feel like this wholehearted re-engagement with all my colleagues and, the residents and the presenter, and feeling like I could support that person, and isn't this fun? And here we are. So there are several different types of educational programs that have been offered to try to create these interventions. Balint is a Hungarian psychoanalyst who's offered and put forth a group model where groups of physicians meet regularly and present cases to each other to discuss, focus on support around medical errors, develop collegiality, and reduce the isolation. Physicians are isolated between your HIPAA confidentiality, the things you can't talk about, the things you're not allowed to talk about, the things you want to protect your spouses and partners from because they're not in that, and so they don't get that, and they're going to be disturbed by that. And so it really creates a sense of isolation. Collegiality is something that no one ever talked to me as a resident about. But in my first job, I realized that the lack of collegiality was the reason I could no longer stay. And after 5 years of being there, I called Dennis and said, Dennis, I need to come home. And he was like, great, awesome. And here, there is collegiality for me, and that's my experience. But that isolation that you can feel and experience without it can be devastating and highly isolating. Mindfulness-based stress response training programs focus on meditation techniques. They promote relaxation through non-judgmental awareness of moment-to-moment sensations, experiences, and reactions. Another type of intervention for educational programs includes cognitive behavioral approaches, where the effects on job-related distress and general well-being are enhanced. Things work. Krasner in 2009 did an intensive program using mindfulness, meditation, narrative medicine, and appreciative inquiry-based dialogues in groups of physicians. And they found that a profound and synergistic effect on physician well-being and quality of relationship-centered care, and that the measures of mindfulness, burnout, and psychological well-being improved with the following. It was a before and after study. They took 70 primary care physicians in Rochester, New York, and they gave them a CME course of mindfulness meditation, self-awareness exercises, narratives about meaningful clinical experiences, appreciative interviews, and didactic material and discussion. 8 weeks there was an intensive phase. They met for 2.5 hours a week and did an all-day 7-hour retreat where they spent 7 hours by themselves, alone, like out, just by themselves. And this was followed by a 10-month maintenance phase of 2.5 hours a month. The main outcome measures were these subscales. And at the end, it demonstrated an improvement in mindfulness, burnout, personal accomplishment, empathy, physician belief scale, total mood disturbance, and personal and emotional stability. They concluded that the skills cultivated in the mindful communication program appeared to lower participants' reactivity to stressful events and help them adopt greater resilience in the face of adversity. The increases in mindfulness correlated with reductions in burnout and total mood disturbance. So this is back to Zwack, who interviewed the 200 German physicians to identify health-promoting strategies. And this participation was based on physician junior to senior levels wanting to share and pass on their own experiences. There was no other incentive in the participation of this study. All had low levels of emotional exhaustion, depersonalization, and high levels of personal accomplishment. And this was complied by their scores through a content analysis method. And it broke down into the following results. They had gratification from doctor-patient relationship, medical efficacy. They felt they had leisure time and activity to reduce stress. They had a quest for and cultivation of contact with colleagues. And many of the people in the studies, one of the folks was saying that when you're, for instance, if you're having trouble with a patient, and let's say you're the specialist, to call back to the primary care person, because oftentimes if the primary care person has sent you somebody to consult, they need your help and they don't know what to do, presumably. But if you're having difficulty with the patient that you sent, to actually pick up the phone, call them, and have an interaction. And that way, your sense of distress about maybe not knowing or having difficulty thinking about something, you have somebody to share that with who also knows that patient. And that can be, I don't think we do that much anymore because everybody's so busy and we just send everything electronically, which increases our isolation. Cultivation of relations with family and friends, proactive engagement with limits of skills, complications and treatment errors, and so, and personal reflection. If you're dissatisfied, why? Where am I? Where am I now? Where am I compared to a year ago? Where do I want to go? What can I do to change that? And so actually stopping and allowing yourself to reflect. Self-demarcation is another thing that came up. Refusing to collude with unrealistic healing expectations from patients. Prevented disappointment and accusations from patients. Physicians who practice demarcation, which is setting boundaries, rather than disillusion, experienced efficacy in the doctor-patient relationship. They also found that this was considered a basic prerequisite for resilient long-term doctor-patient relationships. And the motto they put forth is, demarcation is better than disillusion. Cultivating one's own professionalism, pursuing your own CMEs, organizing yourself, maintaining your priorities. If you need to be someplace for your kid, make sure that you're there. Limitation of one's working hours, feeling like, oh, if I can't go home right now because what? you need to go home. So limit your working hours as opposed to feeling like there's nobody can do what you can do or things like that. Ritualize timeout periods during your day, creating those mandatory breaks that you take and you do something, even if it's 5 minutes, but you build them in to your day and then you honor yourself by taking them. Spiritual practices, get your feet on the ground. Believe in something. I don't care what it is, but it needs to be something other than yourself. Useful attitudes, acceptance and realism, self-awareness, active engagement with needed policy change. So if something needs to change, then you need to get involved. Scott Laker is a model for that. He's involved in everything and making everything happen so we can be happy. So we thank you, Scott. But we all need to be finding our places where we actively engage to make the policy changes that would make us all happier. And recognizing when change is necessary. Sometimes you can't stay someplace. Sometimes I thought I would be at my first job for the 30 years. And then I realized it's like, yeah, this isn't working for me. And this isn't what I thought it was going to be. And I tried everything I need to try, and I need to come back home. Yay. So the other thing that they noted was appreciating the good things. And I'm not sure that we do this a lot. There's evidence for gratitude journals. Are you guys aware of the evidence for a gratitude journal? And that if you keep a gratitude journal, you'll be happier just in the act of writing, in the act of acknowledging and appreciating the things that are good in your life. And to not do that means you're going to be less sad, less appreciative, and less grateful. And this is important for becoming a resilient physician and maintaining the resilience that you already have. So, what is CU School of Medicine doing about any of this? Jennifer Reese, is a pediatrician at Children's Hospital, and in February of 2015, she saw a need for us to get with the program. Georgetown has had a program for 14 years where they have small groups, they meet, they have chocolate on a table, they have candles, they have quietly lit rooms, and they have 8 people that sit around and talk to each other over topics that are pertinent to physicians, and they've been doing this for 14 years. And I'm like, anyway, thank you, Jenny, for bringing this to Colorado. Abby Beecham is a psychologist who's now also trying to increase the resources for physician resilience to help strengthen and maintain the physician resilience. So what is the best model, and where are the resources for nurturing our resilience? So Jenny started with her own personal motivation for bringing this to Colorado, and she's made one-on-one connections throughout many departments and meeting with key organizational leaders. The Resilience Council is something that I'm now part of, and we're still working on program development and growth and starting to move into the research areas for this. The accomplishments, and these are the primary players. There's a website that you can Google right now. It's called it's the CU School of Medicine Resilience Council, and it has a bunch of stuff on there. There's a peer-to-peer support network program. Something goes bad, you feel like you can't talk to whoever you're around. You can call somebody and who is a peer, but again has maybe just an ear for you to work through some things with, and half the time it's just not being isolated in that space where you find yourself, and so that's set up. There's lectures and workshop series with AME. These doctors are doing those. Discussion groups with mindfulness training. This is happening with Eileen Yeager. I believe she's doing this with the medical students at this time. And then there's a residency resilience curriculum development that's occurring. And then improving access to the resilience resources. That's Abby Beecham. She's the clinical psychologist. And everybody's getting on board. So these are super thoughtful folks. And it's kind of funny when we sit together. We meet like once every quarter, and it's just a very different space to sit with people who are just thinking about life and thinking about their role in life and thinking about how to continue on the path that we all started on, of providing excellent, compassionate care, but without feeling like we want to kill ourselves. The website, the peer-to-peer support network I mentioned. Then this was a conference where Jenny Reese compiled 2 really great speakers, Derby, Lottie Derby. So she's she's from Mayo Clinic and probably done the most amount of evidence-based studies to really bring this to the forefront. And then Dr. Adi Harati from Georgetown shared his program and how Georgetown does it. So what's next? Again, trying to look at the multiple-pronged approach to physician resilience from a system standpoint, from a team, and from an individual. So your responsibility is to yourself, and then also to give feedback to figure out what can the system do differently, how can we change the system in which we operate. We're going to want to hear from you. Right now, you could get online and do a resilience snapshot. I did it today. It took me 3 minutes. It's just a bunch of questions, and then Abby Beecham will get back to you with sort of where you are in resilience and where you can be buffered. So hop on the website and do that. And this is your responsibility to yourself and to others. You can also do individual consultation and brief training and/or a referral. There's also life work, personal resilience training, and Koru mindfulness. This is all happening this month and now. The Personal Resilience Snapshot Report is what I was just saying, it's just the questions that you answered took 3 minutes. It's not a diagnostic tool, but then she'll send you a report, so I haven't gotten my report as to how much I'm flourishing or how much I'm satisfied. It seemed like when I answered the questions, I was all the way over here and all the way over here on some things. I don't know what that's going to mean, but we'll see. And then resources will come based on how I answer those questions. And so this is all Abby Beecham. So she's a psychologist. She does one consult visit, but she's not there to become your psychotherapist. But she is there to help direct you to things that will help buffer and strengthen your resilience generally. Any resident, fellow, or faculty member can participate in the resilience things. Again, it's not psychotherapy. And these are the contact numbers for Abby. Yes? Yep. And then there's a new program that we're developing. Where Abby trained with the Swedish psychiatrists who have put this into effect. It's mindfulness and acceptance-based training. It's evidence-based, and it's training specifically tailored to medical personnel and learners. And it's 3 to 4 sessions. It's a practical and skills-focused format. The group is ideal, but she says it's also available in some individual formats. So this is going to be our resilience training model. And Koru mindfulness. Open your mind, manage your stress, learn mindfulness and meditation, and join our 4-week class. You'll be more mindful, less stress, better sleep, and less self-judgment. It was originally developed for emerging adults, 19 to 20 years old, but it's been expanded to everyone at this point. Doing Koru mindfulness, who's not doing it? Everybody's doing it. So it's time for us to get on board, help ourselves, help our system. Join the mailing list. Join the Resilience Council. All your extra free time away from your work and your families. But you'll get regular updates, news and excerpts from media, and sometimes that's just the 5 minutes you need at work just to take a break, is just to be in another place, and that's what mindfulness allows us to do. I know that every medical student that has rotated with me since I started doing resilience work, that's the first question I'm asking. It's like, so are you feeling burnt out? It's amazing what we get. So the residents I'm with, who was that one from, I won't say where she was from, but boy, she just laid it out. And I was like, wow. But I was glad that we were tuned in, we were one resource for her to say, wow, that shouldn't have been that way. And I'm sorry you had to go through that. But that she could have easily been somebody jumping out of an 8th-floor building, easily. And so look out for each other. And that's the other key thing, is that I want us to all look out for each other. So how to heal thyself, physicians. If all of the knowledge and advice about how to beat burnout could be summed up in one word, that word would be balance. Balance between giving and getting. Why I had to get out of my last marriage. But anyway, balance between stress and calm, and a balance between work and home. That's Maslach. That's it. That's all I got. Get home. Questions? Thoughts, discussion, anything you want. Because now you've got like 12 minutes. Yes, Venu. Yes, I wouldn't be able to, I haven't compared and contrasted them. I think Abby's the one, it's got to be Abby and Jenny who picked this one, and I don't know why all those other universities did. I can get the answer for you. I'll ask Jenny. Questions, thoughts, concerns? Make it part of the orientation.
Yeah, exactly.
Yeah. Venu, we'll have to make it part of the... Maybe GME level orientation for new residents. All right, you don't have to stay. If you're free to go. Shoot me an email if you want to talk offline. I'm always happy to have coffee. I'm going to take the residents out. Venu and Dennis totally hooked us up with $750 so we can go sit and talk at the Avenue Grill, PGY 2s and 4s. Look forward to it. We're going to do this. We're going to make ourselves better, stronger, happier, healthier. Nobody's going to be jumping out of things. Oh, honest to God, I have to tell you. So when I was interviewing to be a PM&R resident, and so I got interviews like in really nice places, including University of Seattle. I went out to University of Seattle, and one of the questions I asked them, I said, "Oh, is it true that people commit suicide here because of the weather and stuff?" And every person I asked there said, "Yes, that happens." And I know myself, and so I was like, I can't go here because I would be dead. I would be. And so anyway, I didn't even rank them. I ranked Colorado #1, and I've been happy ever since. Thanks, guys.